My name is Michelle Gavin, and I've worked for the organisation Friends, Families and Travellers for about 13 years now. And I first came to the organisation through working on the national advocacy and casework line. So basically, I'd pick up the phone and I could be talking to a traveller or someone from a nomadic background anywhere across the country with any issue. Many of the calls were health related. As time went on, I was moved on to a health role, which was external. So I was actually doing assertive outreach across Sussex, across all elements of health and well-being. So as a well-being worker, I was supporting a lot of women during maternity, through pregnancy, through depression, etc., and along with many other sort of health-related issues. But before I worked for Friends, Families and Travellers, because what I'm doing now is I'm actually the business development manager here. So I usually co-design all of the training, and also I'm leading on the Health and Wellbeing Alliance now as well. But before I came to FFT, I supported my husband Michael, who, as an Irish traveller man, set his own organisation up because of the he wanted to support his people, his family, his network of friends from the community because of all the discrimination he'd suffered as a young person and growing up into an adult as well. And he really wanted to make a difference. So he did become a spokesperson. Used to talk to statutory services. We used to go out and help people on site, with all the issues that they might have and what was presenting. But I'm mentioning Michael specifically because he was 48 when he died. That was 13 years ago now. It's not unusual in the Gypsy and Traveller community. There was lots of reasons behind it. One of the reasons that he died so soon, and it was inoperable cancer that he had, was because of his very poor relationship with healthcare services. And as a result of that, he managed to avoid seeing a GP. He would never go to the doctor. He would hide his conditions because of the things that had happened to him as a young person and the things that he'd seen happen to his family. And that was one of the main reasons. I often think, perhaps if he was more engaged, would they have been able to do anything with his cancer? I don't know. But that's one of the things that I'm passionate about, trying to improve people's practice and their services and guidance around how you work with Gypsy and Traveller people. So there's my little bit of spiel, and I'll get straight on to the actual slides. So perceptions of mental health within Gypsy and Traveller communities. So the first thing I'll say is Gypsies and Travellers very, very rarely speak about mental health issues. It's seen as almost like a bad luck thing to talk about them. The term mental health is not used. It is really the use of the term, oh, Jane, she suffers with her nerves, or poor old Mick, his nerves have gone against him. It's all about your nerves being bad. Now, the reason behind that, and I've often talked to people about this within the communities, and it sounds because it doesn't sound permanent. When your nerves have gone, it can almost be a temporary thing. When you talk about mental health or serious mental illness, it sounds like it's going to be with you forever. So people are frightened of that label, and there's often a reason behind that because of the negative connotations around the word mental. Often people have very good memories of some of the institutionalized settings that people were taken to as a result of not having, the support in mental health at that time. And also there was a lot of people I talked to of a certain age group within the communities who actually had the shock treatments because of their mental health or schizophrenia. Now, my husband's family, there were several people within the family who had severe mental illness and schizophrenia, etc. But it was always kind of skirtish. There was a lot of people that would sort of self-medicate as a result of that, so with alcohol or with drugs as well, because it was something that was kind of out of their control. So they weren't actually willing to go and see a specialist with regard to their mental health, so they would try to manage it themselves, which of course had dual diagnosis written all over it at that point as well. Now I have to say that things are changing slightly within the community because of outstanding role models like Tyson Fury. Now for the wider community, people probably won't see him much as a role model, but for the Gypsy and Traveller communities in this country, he really has stood up and spoken about his own mental health and used the term mental health. Now, mental health, for him using those two words, Most people with these days, with all of the wonderful campaigns about people's, like it's time to talk and, discussing your mental health and having mental health days at work, etc. Within the community, the fear and the taboo around that, for him to actually use those two words is quite amazing. So what it's done is it's started up a conversation, particularly with men and with women as well of a certain age. There, people are actually talking more about this. This term mental is starting to be used. Mental health is starting to be used. But what I would say, if you're engaging with people from the communities and I would very gently try to use the language that people are using themselves. So take their lead. When someone's suffering with their nerves, that's exactly what it is. It could be depression, it could be OCD, it could be a sleep disorder, all of these many things that come up. We know that a lot of women will avoid going to the doctor about mental health problems. And the reason for this is they're very, very fearful of children being removed from them by children's services. Now, I talk to people all the time. I've worked with many young women. I've worked with older women as well, who are terrified of revealing that they have a mental health problem, or they are not sleeping, or they're anxious because of the real and perceived fear of what's happened historically and today with children's services. Now, the fear is because generally, during the 50s, 60s and 70s, well, 60s and 70s, actually, 70s being particularly high, there were a lot of young people, children removed from traveller families in that era. And of course, that is a real and quite recent historical thing. And that has been passed down generationally to people. My own husband temporarily went into care due to his ethnicity, along with his brothers and sisters. The fact that his parents were Irish travellers living in Manchester at the time, they'd come from an area, they'd come from trailer accommodation. They were living in one room in bricks and mortar because they couldn't get housing at the time. And the kids were basically swept up and put into care, all dotted around the country in different places. And it took them a while to get them out of those care conditions. So these stories are, handed down generationally. And also, there's lots of very high profile incidences, particularly on things like social media and Facebook. There's been some very high profile cases of women, particularly from the Irish traveller community, who have had children removed because of domestic violence. Now, what's happened, there was a particularly a big case particularly that ended up being in the papers in Ireland, actually, where a woman was a recipient of domestic violence. The social workers that came in, they got her away from the abusive perpetrator, but the hoops that she had to jump through, for number one, she wasn't able to read or write. So that they were saying, well, how can you possibly know how to feed your baby? And at the time she said, well, I know if food's on and off because I can smell it. But all of these hoops were put in front of her, and it actually related with her using her youngest child, who was a baby. She was allowed to keep the older children, but not that child. And of course, that trauma was put out throughout social media. So now, people are really, really cautious about revealing things like domestic violence and affecting their nerves. People are very cautious about actually saying anything to their healthcare professional for fear of that being shared with an agency like Children's Services. So, what I try to do when I go out, and if you're working with the community, it's being really, really calm and trying to explain that people will suffer with their mental health, no matter what class background they're from, what a district they live in. It could be anybody, and trying to explain that to people, talking about, people like Princess Diana, for example, who were quite, threw herself down the stairs. She had an eating disorder, and trying to make it seem that it's not just a targeted response. That takes a lot of work to get someone to feel that confident that they can go in and then say to their doctor, their GP, their healthcare professional, their midwife, that they're not feeling well because their nerves have gone against them. Or even being able to vocalize what they're feeling, because in some communities, for example, the Roma community, there will not be words which match, like in the language of Romanesque, which match mental health. It will be more of a physical thing. So someone can say, my heart is hurting, or my breathing's bad. And that will be an indication that perhaps this isn't a physical thing, but it's manifesting itself in a physical way. So this is what the little things that you should look out for, definitely, when you're working with the communities. So usually, as I say, because of the fear, a lot of young women, particularly the younger women, don't actually seek help until their children are of an age where they feel that children's services wouldn't want to take them. So often that will be around the ages of 9 or 10. So I've worked with women who have gone through pregnancy after pregnancy, really suffering, and not actually getting any support or any medication or any peer support for their mental health issues that are coming up. As I said, those perceptions within the community are changing. It's very good if someone is a peer supporter and is able to talk someone through a process. I mean, the fear of even letting people know that you've been put on medication like sertraline or any type of medication for anxiety or depression is another thing that isn't really shared. What you often find is there will be an older woman within a community, particularly if it's a highly mobile community or community that's living on site, who might be the person that goes to the doctors and gets lots of sleeping tablets, something to help with their back, something to help with their nerves, and suddenly has like a whole carpet bag full of different medications. And the younger women will go and see her. It'll be like, oh, hello, I'm going to go and see old Anne. She'll help me. Hello, Anne, have you got something? I'm not sleeping. Here, take these pink ones. They're really good for you. And that happens. There's a lot of sharing of medication within the communities. There'll always be somebody that you could go to for this. But as I said before, things are changing. These mental health, people are speaking about it a little bit more. But if you look at the rates of suicide, in the All Ireland report, for example, 6 to 7 times more likely to die by suicide than the wider population. And that is a huge underfigure count, because we know from our own experiences, from my family networks, from the people I work with, it's high. It's really high. And it's becoming, community members feel that it's an epidemic within their own communities, so they want to do something about it, really. So I'll talk about some of, I think we're going to move on to the next slide here. So in Roma communities particularly, it's very considered a taboo subject. They're considered a brain-related illness as well. So it's, again, taking it to that physical part of the body, and like there's something, some disease of the brain, rather than it being something which happens to, X, Y, and Z people, the wider population. And I've just said it's the pain in the heart, the bad nerves, and depression is definitely more commonly used within the Roma community. But people, again, wouldn't be able to distinguish between the conditions like post-traumatic stress disorder, eating disorder, anxiety. There wouldn't be any understanding of the different conditions under that umbrella term. So Roma women are generally aware that some of them are developing mental health conditions after birth, but they'll usually refer to this in a completely different way, using the words after birth depression. And traditional Roma women of those who grew up in isolated settlements in Eastern Europe will have very limited knowledge of mental health issues and will then use bad nerves again. So you have to look as well to see which country that people from the Roma community perhaps have come from, how recently they've come over. So if you're looking at second or third generation, they might not have that feeling, but going over, say you've come from.
We've muted.
You're on mute now. Sorry.
Okay, am I still sharing or not?
Yeah, you're fine now.
Yeah, you're
okay,
still sharing.
Thanks. Sorry, I don't know how that happened. My hands get carried away sometimes, I think. So yeah, oh gosh, I've lost my thread now when using bad words. So generally, Roma women won't seek the specialist mental health support after birth, as they're considering birth-related mental health to be it's not accepted. I mean, a lot of Roma people from coming quite recently from other countries will not even see maternity, for example, as a health issue. It's just part of life, so it's not seen as a medical thing, as we do in this country, for example, where people are treated a specific way in maternity services in places like Romania, places like Ukraine, Poland, whatever. If you're from a Roma, one of the Roma groups, you might not have access to any of these things. You might just, have very selected access to any healthcare at all. So some of these things it would not be seen as a specialist support. It's just seen as a normal thing, and it's part of life. So Roma will tend to talk with another Roma woman of similar age about her feelings. Another thing that you'll find in group work, if you're working in a group at all, you will find that if there's a 5-year age gap between women, or maybe 10 years in some cases, but people won't talk freely and openly. If you've got a group of young women from the age of 20 to 25, you can generally have a good conversation between them, and people will be honest and share their views. If there's somebody there who's 40 or older, or 35 and older, then people will not say anything. They'll refer to the elder in the community, because of communities having this structure within them about what is correct, what is polite, and how you should hold yourself. It's a way of and that goes across all the communities as well. So that's worth bearing in mind, particularly if you're supporting somebody and there's an elder in the room with them. So it's always really, really important to consider who else is in the room when you're having any conversations, because many people won't want to be in the room. Some people will be in the room and will have stronger views, so the younger person perhaps will not speak up, and vice versa. So it's really interesting about that, really. So Gypsies and Travellers may not be engaging with services at all, because they, that there's a lot of reasons behind not engagement. So a lot of people will feel that services aren't for them. They'll feel very othered. There's nothing there to indicate that they are welcome. A lot of people will find difficulties accessing primary care due to the registration process and not having a fixed address. So if you're highly nomadic within the UK, that is an issue, and it still is. On our website, if you want to have a look at gypsytraveller.org, we did a sort of like a health study and a survey, a mystery shopper review of people who were trying to access registration. And we did one before COVID and we did one during COVID, and the results are quite shocking. It goes against the institution, goes against the constitution of the NHS, and the fact that you don't have to provide ID documentation in that respect, but most or many surgeries had vetted processes, or they could only let you sign up if you were digitally included, or you needed to do form filling, but there was nobody there to support you with the form filling. There was no social prescribing service, or they didn't feel that because you had no fixed address, you weren't entitled to be there. So the list is long, but if you go onto our website and have a look at the results, you'll see what I mean by this. And so people are having lots of problems still if they're highly mobile registering. Also, there's a lot of bad experience, as I've said in the past. My husband is giving an example of a general health with bad experiences, but there's a lot of people that have bad experiences through maternity care as well. I've worked with a lot of women who often will come and book in from all over the country to go to Brighton to have their maternity care, because there's a specialist traveller midwife in Brighton out of the Sussex Trusts, and the first thing that people recognise is they won't be questioned. They won't be asked what people feel are silly questions, or questions why, where's the water in your trailer, or how do you do this, or where do you go to the toilet? All of these things, because people haven't been culturally trained or to understand what the culture's about, and so they'll ask things that make people feel uncomfortable. They might often not have an understanding of the gender situation within the communities. For example, men and women will not discuss any health problems in the same room. Your husband will not discuss your health problems with you, and vice versa. You won't, after birth, with traditional families, for example, the husband won't be involved in that. The husband generally won't be involved in the sort of like scanning processes, being in the room with somebody when they're discussing a pregnancy. In fact, some traditional Romany families indeed will not discuss pregnancy at all. People wear very baggy jumpers. It's not spoken about because of the talking of, you don't talk about sex with your husband, with your father in the room. And obviously, if you're pregnant, you can see that there's been a sexual act. So it's really, really nuanced, and you have to be aware that it's very different from the wider community. With Roma families, it's even more strict in practice. Some Roma communities, I'm thinking of Greece particularly, they will never speak that they are pregnant. It is literally, you'll have the baby, and then after that, it's not spoken about. A baby turns up, literally. So it stems right back, and there's something called purity laws as well. So a lot of people from the Roma communities, in fact, will hold this a situation where they won't they won't go out the house for X amount of days. It could be up to about 40 days, particularly in the Greek communities. The husband will often move out of the home, and female members of the family will come in and they will prepare the food and they will do all the chores related to the home. At that point as well, it is the opportunity for mum to actually bond with her child. So it will be very much where mum hasn't got to prepare anything other than look after the child. So it's a two-way thing, because they call it purity, or it's called mogadi or mogadi, and the opposite of that is sutri. And what mogadi means is basically it's dirty, it's unclean. So during that period, you would not prepare food for your family, and your husband won't be around. After that time, it all goes back to what would be classed as normal. But because of that, there's often problems related to women being excluded during that postpartum purity period. So people won't come perhaps out to the home. They're expected to turn up for X, Y, and Z. And women stay at home for the first 1 to 3 months postpartum because it's a culturally expected belief that's held. But there's a lot of miscommunication about that. So sometimes you get things flagged up like, well, they're not engaging with us, I'm going to call children's services. Or why haven't they had, they haven't had to talk about preventing cot death or breastfeeding, or, talking about some of the things that are really important, and people are missing out on that. So it's worth bearing this in mind and trying to sort of like shift the way you practice something, in the sense that don't expect people to come out to you if they are taking part in this purity period, which is quite normal in the Roma communities. Think about outside the box, and just talk to people, keep it open and be honest and straightforward, and people will explain to you. We also have past bad experiences, unintentional bias. So, there is, I've just said about the traveller, specialist traveller midwife service in Brighton, which people really find good. But it's not necessarily that you should just direct people to a service that is specifically traveller led, because a lot of people just want the same equitable service that they would get from anywhere. So I've had that in the past where women have said, oh, they're trying to put me with this midwife, but I'm happy at my surgery. Why are they trying to put me over to this particular midwife? And it's like, I've had to go back and support that person to be able to voice why they want to stay with their surgery midwife, the one that's normally attached to that. So it's really about being fair, equitable, and understanding if somebody wants something a bit more specialist, they can have it. It's an additional service, but people should be given the opportunity to have the same service as everyone else. One of the big things, and we've just gone on about language a little bit, but use of high words. So people will say to me, Michelle, I don't understand these high words they're using. What do they mean? Basically, it's jargon. So health specialists use it all the time. I use it. We all use it. We get used to using it because that's what we do when we're professionals. But people outside of that have no interest or no knowledge of what this jargon means. So even things like postnatal depression, that's something that most of us would use. In the community, that doesn't mean anything. That's not something that people recognise. You might be able to use something like baby blues or after baby blues, because that's something that is shared and spoken about within the community. But if you start talking about postnatal depression, people get anxious. It's like going back to that, oh, your mental health. I'm not mental. Yeah, my nerves are bad at the moment, but I'm not mental. This is the sort of thing that comes out of, not using high words and jargon, because within the communities, we're talking about very low levels of literacy. At FFT, I think we take up about 4,000 pieces of casework a year. And during that period, I think it's about 47% of the people we take up casework for. Can someone's got their hello? Someone's got their cam.
We're gonna swap.
Hello.
She just had a meeting.
Hi. Can someone turn their microphone off?
Don't worry.
Michelle, you've knocked mute on by mistake.
Hello, I'm back again. I don't know why I keep doing that. I think I'm trying to turn everyone else's mic off at the same time. Thanks for that. So basically, we know that you know, going back to the jargon and people using certain things that way, I've lost my thread slightly there, will having the lack of literacy will really impact on someone. So people feel more isolated with the lack of literacy. 47% of the people we work for have no or little literacy. It's very low functioning literacy, and that can be quite upsetting, because if you see things written down in a way, you know, with heavy words, lots of text, people feel already that they're on the back foot. So think about how you could possibly change that by being a lot more verbal in your communications with people, because we tend to think people can understand the same levels as we do, and it just isn't the case. So not having access to post as well is a problem if you're highly nomadic. We keep the mail for about 300 families here who are highly nomadic across the country. So they receive mail from hospitals or health appointments, and not having that access to the post, it can actually really impact on someone's services. So, you know, someone might be in the service, and it could be a mental health service within that, but if they haven't responded to this piece of mail, you know, if you have 3 strikes, you're out generally. So there's not a lot of understanding about what is inclusive communication with people. People in the community tend to use communication like WhatsApp messaging because it's easy. You can do a voice clip with that. You can talk to somebody. You can even take a photo of the letter and then send it to somebody, and then someone can voice clip back to you, and it's you know, it's really safe because it's encrypted on both ends, and it empowers the women within the community to use it. And you know, they're not having to go, oh, can you read this for me straight away, and can you write this, and I need to do that. People are having it instantly, and people have access to it, so it's the best. The reason I know this is because when I first got my work phone, and then I thought, oh, I'll try that WhatsApp app. It looked quite interesting. And I downloaded it, and within minutes I was pinged left, right and centre from my clients on my phone at the time, and I was getting, hello Michelle, it's Pat here, can you look at this letter? Oh yeah. And I was like, where's that noise coming from? You know, and I actually learned from the community, and that is the best way to communicate. People really do communicate that way. It's something that's come really from grassroots, so that's worth bearing in mind. Missed appointments, because of that communication method, is really common as well. And also missed appointments can be because people are suddenly having to be moved from one place to another. There could be evictions. If people are on the side of the road, they might have minutes to go, you've got to move from here. There's new legislation now which is even more sort of draconian, which impacts on people. It could be that you're out of a district where you've got any connection at all to Wi-Fi, or you've got a poor connection for the telephone. It's just, there's a lot of reasons why people might miss appointments, and that digital exclusion is huge. So if you're on the roadside, number one, you won't have a Wi-Fi access point, you know, so a lot of people are on the road, they'll actually drive near like free Wi-Fi point and then log into that. So a lot of my clients will go into McDonald's to actually use the free Wi-Fi. But if you imagine, if you're trying to contact an NHS service on a free Wi-Fi point, that's not secure on either side. And if you've only got data, the data gets eaten up very quickly. We all recognise what happened during COVID and how people were digitally excluded because of poverty, or because they didn't have access to Wi-Fi settings. You know, all of those places were shut down, and you know, and a lot of Gypsies and Travellers are also in rural settings, so they might not have, you know, the high-speed internet, etc. But digital exclusion is huge. So people may only have like a smartphone, and some people wouldn't know how to use that smartphone properly either, not in the sense that you can run an email account from it, or you know, you can take photos that you can send to your healthcare professional, etc. So it's really worth bearing in mind, you know, that's why someone might not be engaging with you. Okay, next.
Can I just ask a question about
Sure,
digital?
absolutely.
Sorry.
Yeah.
I don't think you can see us putting his hand up, can you, when you're...
No, just, yeah, shout out because I can't see you, so please do.
You might not know the answer to this, but I just thought I'd ask while you're on. I have been told that lots of Gypsy and Traveller communities are quite comfortable using YouTube, and I wondered whether that was anything anybody's explored in helping to sort of talk about what services were available.
It's fantastic. People do use YouTube, and people do use Facebook platforms as well. So they'll have a YouTube video and share it on Facebook or whatever. And that's really good. What we do at FFT is we often, when we're getting messaging out to community members, we will do some co-development and do a video with someone from the community. Like we've just done one recently, and it's about, did you know about the NHS app? And one of our Romany women was happy to be on camera talking about, I've never heard of the NHS app, and then explains how you download it. There's a picture of the app on the side, and then what she's been able to do on this app. And she says, my mum's not got any literacy, but she's been doing X, Y, and Z. And you can even, it says, it even has like a talk aloud if you've got an iPhone. And if not, you can download Browse Aloud and how you do this, and you can book appointments on there, but you can also get ringbacks and all of these things. So, and that, I think we did that last week, and it's had so many shares. It's gone right the way around because we have a lot of closed Facebook groups for community members, but it's gone beyond that. So we know that videos are really, really good. People like visual explanations, and also people resonate with people that they recognise. So if you've got someone who's a Romany woman talking in the type of language that people understand, then it's going to be shared. It's as simple as that, because there's a lot of peer cascading of information within the community, and people trust community members. So that's a way of actually engaging better with the community members, and Roma as well, very much involved with doing videos too. And also thinking about different languages as well within that. So Romanesque is something that can be used in those if you're getting the community to talk. So that's the way forward. So
that's really, really helpful. Thank you.
Thanks, Rebecca.
I don't suppose you could share that video with us.
Do you know what I will? What I'll do is at the end I'll give it to Celeste and see. I'll have to get the link for it, but yeah, I'll show you the one. We've done quite a lot. We did one around vaccinations. We've done quite a few. So I'll see what I can get you, and I'll get her to share them out. So that's cool. All right, lovely.
That's brilliant. Thank you.
That's okay. So, I mean, going back to why Roma may not be engaging with services, it's very similar stuff. Referrals and signposting for mental health may be misunderstood. And that's one of the things. People are really fearful, again, as women won't actually understand what the health specialist is speaking about, because there is not that explanation within the language itself. Roma do not understand how these things will help, because it's almost like, there's if you've got a broken arm, they know you can go to the doctor and get it fixed, but it's no understanding. There's a really perfect example of this. It's not to do with maternal health, but a woman her son was diagnosed with autism. And the family, they didn't understand why he was different from the other children. And when he was, it said he was autistic, the parents sort of like looked and okay, that was it, and then stopped engaging. And the reason why is they thought that they were going to be called in for their child to have some type of surgery to make his autism go away or better, because they did not understand that whole diagnosis of autism. And so at the time it was flagged up that they weren't engaging with services, and children's services came out, and it was a real misunderstanding and a miscommunication. So once they were supported to understand, they were able to engage back with services again. But some of these things, they get flagged up very quickly to child protection services, and so then Roma and people become really anxious about this. So it's like a bit of a cycle, really. So when Roma women who do understand the referral and want to engage with mental health services, they might miss appointments as well. And that's if they're sent appointment letters in English only, because that's a common problem. Roma usually have very low literacy and very limited English level. So again, depending how long the family unit have been in the country, it might be that their children have got a very good level of literacy. But again, it's not really appropriate for young people to be reading any health-related information to their parents. It's something that just it shouldn't happen. It's seen as disrespectful, and so some of these things will never some of these letters would never get read. Sent only text messages to confirm appointments, and some Roma change their phone numbers often. So those text messages can be quite confusing as well, because particularly if someone's got lots of different services from the hospital or from whatever health service, the text message will probably be a no reply text message, and it could be from any service. It could be from ophthalmology, it could be maternity, it could be, you know, mental health, it could be anyone. You know, people have multi issues going on, then they don't know where that text is coming from. And if the appointment date is too far in advance, no reminders are sent. That's an issue as well. So what we do with our community, we normally ring people up or WhatsApp them, get in touch with them if we're, you know, doing face-to-face work, you know, and keep regularly reminding, or actually going, you know, particularly like we tend to do it like a couple of days before as well, as a minimum, so people remember that they've got something, because people's lives are very busy. If you're highly nomadic, going back to Gypsy and Traveller communities, you know, you things move on very quickly. So, and if appointment details are only confirmed by email, Roma people don't usually check their emails and often lose access to them. It's the same with Gypsy and Traveller people. If they do have an email account, many of them wouldn't know why. I did some research around digital exclusion, and I was asking people if they had Facebook, and many will say, yeah, I've got a Facebook. And the next question was, do you have an email account? People go, no. And they hadn't realised, you know, basically their Facebook account had been set up by someone who'd found an email for them and done it that way, but they had no control on their email account because they didn't know they had one. So these are really interesting things that come up, and you realise. So if important family events come up, child christening, wedding, funeral, that might be an issue. And it's exactly the same in the Gypsy and Traveller communities. These events are seen as really important. They're part of the cultural, they're part of the belief system. If someone has passed, everyone will go to visit that family, and they'll be part of the whole burial and bereavement process as well. And that means sometimes that people will be gone for 2 weeks. If you're from the Roma community and someone has passed and they're from Romania, for example, they will be flown back more or less straight away back to Romania to be buried, and the family will go as well. So it might be without any notification that a Roma family might not be engaging, because they're expected culturally to go and attend this event. And this is what happens. It's really, really important. It's the same with weddings and christenings too. Let's just move on to the next one. Some recommendations that you could use to improve access, specifically for Gypsies and Travellers. Mental health professionals, it's a good idea to actually get some training on some cultural understanding for Gypsies and Travellers to make that services more inclusive. And that sort of training, we normally talk about things like, you know, understanding the process and procedure behind when someone passes, for example, end of life care, but how that's relevant for everyone that's living. We'd also talk about like the language use, understanding, you know, what can be said, what can't be said, site etiquette. I have some great stories about site etiquette. I remember this, my colleague won't mind me talking about this, but she lived on a site in quite a rural site, and very sadly she had a miscarriage. She's got a couple of children. She had a miscarriage. She was absolutely devastated. The whole site knew, because site living is kind of like that. She'd told everybody that she was expecting a baby, and of course she, you know, lost this baby through a miscarriage. Anyway, she very quickly after this event became pregnant. And she took the decision that she did not want to tell anybody until they were very way into the pregnancy. And that was agreed by her husband and her family as well, because she didn't want to go through that trauma again. Anyway, she had a visit out of the blue from, obviously she told healthcare professionals and services, she had a visit out of the blue by a midwife and a health visitor on the site. And it just so happens on this day, she wasn't there. And they went up, they came in like a car which had NHS written on it. They came in with like lanyards and, you know, bags and, you know, what service they were from, basically. They knocked on her trailer door. She wasn't there. So then they went on to knock on her neighbours' doors, either side, and find out where she was. And it was very obvious to the neighbours that they were from this particular service. So they left because, you know, obviously she wasn't there. But by the time she got home, everybody on site knew she was pregnant. And that caused her an awful amount of stress and discomfort. Now, I always say to people, it's almost like people almost lose their minds when they go onto a traveller site, because all the things that they know that they wouldn't do for the wider community seems to go out of the window as soon as you go onto some area of sort of like a communal setting of where people live, because there aren't any sort of like walls up, and it's very open in a lot of ways. So I always say, would you go and knock on the next door neighbour's door if you lived in bricks and mortar to find out if they knew where the neighbour was who was pregnant? No, you wouldn't. So this is some of these little things, these key things, also about being really mindful about services. If you have a male midwife, for example, that would not be appropriate for a majority of people from the communities, because there's very strict rules around gender there. So emergency procedures, etc., it is accepted generally that people will, they're very grateful for any emergency service, but if it's elective care or anything like that, it would be you get better outcomes, and it's more culturally appropriate if people are the same gender that are working with them. So that's one thing. So some of these training on cultural understanding can definitely make your service more inclusive. Maintaining trust and relationships with the community, people to be a constant part of their mental health journey, ensuring promises are kept. So if people are going to disclose that they have a mental health issue, they would not want to see lots of different practitioners, because that would make them feel very anxious and they wouldn't trust that. And I think the wider community are a little bit like that as well, but generally even more so because of the difficulty of people actually revealing that they have an issue with their mental health. And going back to, I've got a problem with my mental health, my baby's going to be taken off me. So lots of things are hidden, and it's not even recognised. Like OCD is a huge issue within the community anyway, but often that happens just after pregnancy, just after a baby's been born. And and it's a way of control, and it's not just about washing, but like the intrusive thoughts, that people would find it very difficult to share that. And the problem with this is there's not a lot of information out there generally for people from the communities that will be written or spoken about in a culturally sensitive way to make them realise that actually this happens to all communities. Again, my daughter, Irish Traveller background, she had terrible OCD as a result after having her child. She couldn't sleep for 2 days. She was in a psychosis. She was so frightened that something was going to happen to that baby, and she had all these terrible thoughts, and she had problems breastfeeding, and it was just a terrible, terrible time. Fortunately, I'm part of her family as well, so I was able to support and get the right services in. But for many people, many of the mums or aunts would be struggling to support, because it's, again, something that we don't talk about within the community. It's something that's like, oh yeah, no, that's fine, we'll brush that under the carpet. We don't want to bring trouble to the house, and that's an issue. But recognizing and maybe just saying the right thing, or it's the baby blues that aren't that are affecting your sleep, or this or that, oh, that happens to this, and people are more open to it. So those sort of recommendations, really, really trying to break things down and try to make it sure that people know it happens to everybody, not just people from the Gypsy and Traveller community, the Roma community, the whatever communities. That it's something that happens to everyone. Don't do digital by default service provision, because that information has got to be available in all accessible formats for those with low or no literacy and those experience digital exclusion. And what we've found as well, doing some maternity research, is people really, really do get overwhelmed by all of the forms and bits and pieces, and they just that few extra minutes of actually talking to somebody can make a huge amount of difference as well, making sure everything's read back and people understand. Because people, in my experience, when I've gone into like appointments with people, I'll often see the fear in their eyes, and they're looking at the doctor or the healthcare professional, and they're nodding, and they're going yes, yes, and all I can see is the side eye at the exit. And then as soon as we get out the door, it's like, oh, can you tell me what they said? I didn't understand a word of that. And it's because people are fearful, because they might have had an experience. So going right the way back to those experiences people might have had. And voluntary service organisations as well providing specialist services like bereavement or anything like that, they should work with organisations like FFT to ensure that they're accessible to reaching those communities, because I know that there's been a lot of cuts, but bereavement support often done in groups is not appropriate because people already feel like they're being targeted as different. You know, if you look at how discriminated the communities are by the media, and if you look at societal attitude studies, you know, 47% of people for a Pew study said that they wouldn't want their child to have a play date with a traveller child. Similar amounts wouldn't want their children to be taught by a Gypsy, Romany or Traveller teacher, even if they're qualified. So we know that these are really embedded. So it's really reaching out to people like FFP and others around the country to ensure that, you know, their services are being, you know, inclusive, really. And then, and some actionable recommendations to improve access for Roma. Again, you know, sort of like developed targeted, accessible campaigns involving Roma communities to inform community members of mental health and support available. So, you know, going back to those YouTube videos, or going back to, you know, what's important to people, how would they like it to be said? And, you know, because other things, it will just, people, I did some work recently with the Nuffield charity, Nuffield Trust, and they had some leaflets that they were putting out for some of their free programs. One was around COVID and another was around musculoskeletal. And I did a focus group with quite a lively group of demographic of traveller men and women, and we were reviewing what they said. And honestly, it was quite funny in parts that these are very modern sort of leaflets. There was a woman looking out to the distance with a smile, and she's, you know, got a dog on the lead, and everyone thought it was a dental sort of leaflet. Turns out it was for COVID-19. So everyone was going, what on earth does that mean? So there was all sorts of things you could pick through to say, this leaflet does not resonate with me, my culture or my community. But there are things that you can do to make them more inclusive. It could just be like putting a symbol on it, like, you know, a Roma wheel or the flag, or it could have, you know, something that shows you that actually it's inclusive for all communities. So that's worth looking into as well. Working with bilingual Roma advocates to facilitate access to mental health services, to provide interpreting services. That's really important, because those interpreting services often will go to things like, okay, I'm using the interpreting service, it's for someone who's come from Romania, they're Romanian Roma. Now, it's possible that the interpreter will be interpreting the Romanian, which would be a second language to Roma people. And sometimes, with the amount of discrimination that people are met with in home countries such as Romania, it's likely that that particular interpreter might not give a true interpretation of what someone's saying, because there's a lot of mistrust, there's a lot of prejudice within some of the Eastern European countries as well. So that is really important, so to seek out bilingual Roma advocates. To, you know, they have to come from the Roma community, because otherwise, you know, it will not be a fair representation. A lot of people are expected for their families to interpret for them, but that is just not appropriate, because that's when issues happen, when people end up having catastrophic events where people can end up, you know, in the worst case scenario, a fatality comes from it, which has happened in the past as a result of this. So it's providing those accessible opportunities for Roma women actually to learn of mental health conditions and services available to them before birth. And that's one of the things that comes up as well. It's almost like bombarded with things after the event or during the event, which is a difficult time anyway. But before people and also trying to include that very early, perhaps before pregnancy even. That's, you know, it's a challenge, but I think it would be much more conducive. Right, so I'm going to stop sharing, and then I'm going to hand over to you to ask me some questions.
That was really, really useful. Thank you so much.
Yeah,
Thanks.
thank you.
Lovely.
I've learned a lot, and I've got lots of ideas as well. So thank you very much for that.
Brilliant, thanks. Okay, I can see, is it Abby McKee?
Hi, Yes,
Hi.
thank you. Hi, that was absolutely amazing. I really enjoyed that presentation.
Thank
Thanks
you.
so much, Michelle. I've taken loads of notes, so it's great. I had a brief question around like adverse events or adverse outcomes within the community. My understanding is that there's perhaps a higher likelihood of adverse events. I wondered if your organisation has experience of maybe working with those families or advocating for those families, or if you had any sort of insight to share around when those situations happen.
Well, when something bad's happened in a service, you mean adverse event, or
if a
pregnancy,
family-
or a family have well, yeah. I mean, I've got a, we do a lot of advocacy work. We try to get people into the mainstream services. So if there's a complaint, for example, around a maternity, I'm thinking of one particular situation that happened some time ago, where a woman, a young Romany woman, ended up in hospital and was was made to have a C-section, and at the time, it didn't seem like that she needed it. She was sort of thinking, why am I having this? And actually, the anaesthetic didn't work, and she was in absolute agony, obviously with this C-section, and it was the most traumatizing birth experience. In fact, to the point they actually brought the child out to the grandmother, who was out in the hallway, which I've never heard before. It was a really traumatizing event. She, as a result of that, had incredible post-traumatic stress disorder, and when people within the communities generally like to have quite a lot of children. She's only had the one child. All sorts of things happened as a result of that, but she didn't know where to go with it. She couldn't get answers. So we were able to have one of our outreach support workers go and advocate for her, go through the proper procedures and get support from specialist organisations who helped women in areas like this. She would not have engaged in that herself. She needed that trusted intermediary, trusted. So we do that a lot across any adverse events, so that's just something that I can sort of relate through this, and the levels of, I think one of the things that I find really quite sad, I've just done some research, I've just done quite a few focus groups with women, and I asked the question at the beginning, like, how many children have you got, and then asked how many pregnancies have you had, and literally every woman I've spoken to has had more pregnancies than children. So whether that's through miscarriage or whether that's through stillbirth or whatever. And I asked all of them, had you ever had any support after these events? And not one of them had been given any counselling support or any mental health support around that at all. So that's an adverse event, full stop, but feeling like that that's not for them. They've not been offered it. It's really interesting. I'm obviously, it's like the tip of the iceberg, because I spoke to about, 40 different women, but they all had something that they could add to that. So there's a lot more research needs to be done. And how do you stop that? How do you improve that? Having those conversations as well.
Thank you.
Okay. Is it Julie? Are you next?
Yes.
Hi, Julie.
Hello. Brilliant. Loved every minute of it. And like the lady before, I've got like loads and loads of notes here. You did mention training.
Sure.
So is that something that you provide? Oh, brilliant. Okay.
We do. Yes, we do. I'll drop if you contact me directly. I've developed and designed in co-development training with people from the community. So we always actually deliver it with community members as well. So
fantastic.
I think one of the things that I really like as well is the fact that it's fresh, because we're working with people every day, and I think the fact that we have a very large outreach team and we have like a national team, we're really working at grassroots, so we get that lived experience all the time. It's not just something that's sort of like we churn out the same stuff. There's always something that can be learned through some of the case studies. I think that's really important. Brilliant.
It's quite interesting, but also I work with victims of domestic abuse.
Right.
And
yes.
I have recently been passed a lady to work with that has left the traveller community.
Yeah.
So
okay.
Is there any advice you can give me? It's taken me a little while to get confidence.
Yeah. Just email me, Julie, and I'll give you, we can arrange a meeting outside of this, and I'll give you some ideas.
That.
Okay, that's
Thank
fine.
you so much.
Lovely. I think Laura Laura Brindle, Bidle, sorry.
That's okay. Thank you so much. It was echoing. Thank you. Very, very helpful. And it was great that you mentioned about support for after loss, because that's kind of where I'm working with at the minute. I met with one of the midwives who supports the traveller community in South East London, and we're trying to see how we can best kind of meet with the community to offer the psychological therapy that's being offered around loss, and how we do that without scaring them off from the get-go.
Okay, that's good. Are you working with are you near Southwark at all?
Yes.
Southwest London. You are. Well, there's a group called Southwark Traveller Action Group.
Oh,
STAG. So go to them. They're very quite Swiss, but they've got members, and they've predominantly Irish travellers in that group as well. I sit on one of their steering groups, actually, the committees, but they're very open to doing some engagement talks. So if you contacted them, give them a shout.
Hey,
Anyway,
awesome.
all right, Laura.
Thank you. Yeah,
okay.
Thank you.
Brilliant. Okay, I've got 2 with unknown users, so make yourself known before we get thrown out. Who's next? Unknown user. Anyone got any other? Just shout out if there's any more questions. Lovely.
Hello, hi.
Hello, Siobhan. Hi.
Michelle, thank you. That's been so interesting. Absolutely fascinating. And you know, I'm really interested in the kind of the diversity and kind of the inclusiveness. And I'm just curious, and obviously this is a generalization, but my role, I'm an ex-midwife, but I am now a psychotherapist, and I work in the perinatal community mental health team. And I'm just interested in, you know, kind of how receptive, like when you were talking then about the lady who's now got PTSD, the kind of ladies that we look after have moderate to severe mental health problems. And the kind of specialist work that I do is around trauma. I'm just wondering how receptive, as a generalization, the ladies are in terms of having something like EMDR or therapy. I mean, how?
It's interesting. You know, a lot of the therapies that are offered are CBT, aren't they? Sort of those sort of therapies which we've asked a lot. Now, I know quite a few members of people I've spoken to, particularly in areas like Surrey, different particular areas where they only offer that by online. So that, number one, is something that people can't engage with, because like if you have got illiteracy even, and you're trying to understand, it becomes a really anxiety provoking thing trying to do CBT therapy online if you've got low literacy. So that's one of the barriers that I would talk about. I would talk about there is no receptive area. Some people will, some people won't. Some people feel that if they talk about something, have a talking therapy or anything like that, then they will be re-triggered. So there's a lot of that around people, but people are willing to try things provided it's really explained. And I think that's what I will say. If things are really bad, then they really will try to engage with that particular therapy.